Hello doctors. Today let's talk about pneumothorax and I'll tell you how to solve the questions asked on this topic. Now, when a question is given to you describing that the patient has chest pain and difficulty in breathing, and when you auscultate there's no breath sounds, when a question like this is given, first you have to check the answer of first the result of percussion. Now, percussion is just tapping over the chest and listening to the sounds. Normally, the normal sound is resonant, but when you are given the patient has a dull sound or a hyper resonant sound, there are different diagnoses for this. Now, how does a dull sound appear? If you see this can filled with water and if you tap this, the sound you hear just like that is the dull sound. And if you see this drum in this drum it's filled with air, so when you beat the drum or hit the drum you may listen to a very big noise, so that's hyperresonant. The dullness is basically due to some fluid inside the cavity, and the hyperresonant sound is just because there is air inside the cavity. Now let's relate these examples to a human chest. Now when there is dullness, the most probable diagnosis could be pneumothorax. That is, there is blood inside the pleura. So when you tap the chest or the thorax, you hear this dull sound. It's because of the fluid, the blood. So to treat this, just you have to put a chest tube and drain the blood. And for the hyperresonant, just check in the question if the chest X-ray results are given or not. If given, you have two differentials. Check for the trachea. If the trachea is deviated to the same side in which the lungs are shrunken, or the abnormal side of the X-ray, if the trachea is deviated to that side, then it's a spontaneous pneumothorax. What you have to do is insert a chest tube and give 100% oxygen. But if the trachea is deviated to the opposite side, for example, the lung is shrunken or there is air in the right side of the chest, but the trachea is deviated towards the left side. If that's the case, then this is tension pneumothorax. You have to do immediate needle decompression and then chest tube drainage. Now what I am teaching you is just for exam solving, question solving purposes. But in real life, whenever you suspect a tension pneumothorax, it is not necessary to perform a chest X-ray. Directly you have to do the needle decompression. Just for solving the questions, I have given this algorithm. If you see in this image, in the right side you can see there is dark, but in the left side you can see there are some markings. These are the vascular markings seen. But if you see in the right side, there is no vascular markings because the lung is shrunken and all this is filled with air. That is pneumothorax. If you see this, you can appreciate the lung parenchyma or the lung tissue that is shrunken. That is because of this air in the pleura. This air in the pleura is compressing the lungs, so the lungs are shrunken and the vascular markings are only up to the lungs and not into the air. Now next thing you have to see is the trachea. If you see in this, the trachea is deviated towards the left side. So this signifies that it is a tension pneumothorax. So do needle decompression and chest tube. Now let's see the mechanism behind using 100% oxygen in cases of spontaneous pneumothorax. Now imagine that this is the lungs and outside the lungs is the pleura. In pneumothorax, this is the lung and the pleura is filled with air. Now what do I mean by air? Air is oxygen plus nitrogen. Air is oxygen plus nitrogen, that is filled in the pleural spaces. Now just near the lungs there are capillaries which contain blood. In that there is oxygen and nitrogen. But when you give 100% oxygen, what you do is you kick off all the nitrogen molecules and the capillaries is filled with 100% oxygen only, no nitrogen. So when the capillaries are filled with only with oxygen, the capillaries are now asking for nitrogen. So if you see in the capillaries there is absolutely no nitrogen. So wherever the nitrogen comes from, the capillary would get it. In this case, the nitrogen is in the pleural spaces. So there is a gradient for which the nitrogen would go from the pleural spaces into the capillaries, because in the capillaries there are no nitrogen at all. By this way, you can reduce the amount of pneumothorax to half. Most of the cases would require just 100% oxygen, but some cases would require chest tube insertion. Chest tube is also called as intercostal drainage tube, that is inserted in the triangle of safety. This triangle of safety is just located below the axillary fold. Medially is the pectoralis major, laterally is the latissimus dorsi, and in the inferior border it is the nipple or fifth intercostal space. If you insert your chest tube here and drain the fluid or air, there would be less damage. Then for the needle decompression, it is usually done in the cases of tension pneumothorax. It is usually done in the second intercostal space. If you see, this is the first rib and second rib. So between them is the first intercostal space. Then between the second rib and third rib is the second intercostal space. In the second intercostal space, at the mid-clavicular line, this is the clavicle, and in the middle of the clavicle there is a line passing by, an imaginary line. So you have to insert a large bore needle at the second intercostal space at the mid-clavicular line and suck the air out. Just syringe the air out so that the patient would survive in tension pneumothorax. This is just an emergency procedure. Now, when this chest tube or the needle decompression doesn't help, you have to go with thoracotomy, that is opening up the chest. It is usually done in cases where there is significant ongoing hemorrhage from the chest tube, or the initial chest tube drains more than 1000 ml or 1 liter on penetrating injuries, or the chest tube drains more than 1.5 liters on blunt injuries. Then the ongoing drainage is more than 200 ml per hour for 3 consecutive hours. So for 3 hours there is for every hour there is more than 200 ml of blood running out of the tube. You have to do thoracotomy. Then whenever there is a great vessel injury, that is like aorta and pericardial tamponade, that is when the blood is filled in the outer spaces of the heart and the blood is compressing the heart and the heart couldn't work properly, you can do thoracotomy only on chest trauma cases. And cardiac herniation, tracheal or bronchial injury, which is the immediate cause of death, and esophageal perforations and air embolism. For all these, you would require to do a thoracotomy. Thank you for watching this video.